Hello everyone. Today we will discuss on febrile seizures, which is a very common condition that we encounter in pediatric practice. Overall, you can see that the febrile seizures are one of the most common convulsive events that happen in the childhood, and it affects almost 2 to 5% of the children aged between 6 months to 60 months. That means roughly around 6 months to 5 years. It is very, very common. Something that is lasting beyond 5 years, we usually give a label of febrile seizure plus, and if it is a genetically family is also getting affected, we usually use the word called as GEFS plus. So, which we will discuss further. So you need to understand that febrile seizures overall affect 6 months to 60 months, and it is very, very uncommon beyond 5 years of the age. And we broadly classify it into simple febrile seizures and complex febrile seizures. Now we use the word called as simple febrile seizure when the seizure is generalized. That means it is without any focal component. Spontaneously, there is a cessation of convulsion within 15 minutes. That means the convulsion that's happening is less than 15 minutes. One convulsion in a 24-hour period, and there are absence of any pre-existing neurological abnormality. So that means if you have to understand that if the seizure is associated with the fever and the seizure is generalized, it is lasting for less than 15 minutes and only one convulsion is happening in a 24-hour period, we use the word called as simple febrile seizures. So if the three of these criteria are not fulfilled, we often call them as complex febrile seizure. So complex febrile seizure is when the duration of the seizure is prolonged. So we call them as prolonged febrile seizures, right? Or if the seizure has focal manifestation, that means the child had a fever and a seizure which is focal in onset. That's again a focal febrile seizure or a complex febrile seizure. Or if the febrile seizure is recurring in 24 hours, that means one episode of the fever and one or more than one episode of convulsion happens, then that means this is a case of simple febrile seizure plus. We often use the word called as SFS plus when otherwise it's a simple febrile seizure, but more than one episode, that means two episode, three episode, or four episodes happen within 24-hour period. We call them as complex febrile seizure. So the answer is very simple. If it is a generalized seizure, seizure is lasting less than 15 minutes, one convulsion within 24-hour period, we call it a simple febrile seizure. If the duration is more than 15 minutes, that's prolonged febrile seizure. Or if the seizure has focal manifestation, or if the seizure are multiple in episode, then we call them as complex febrile seizure. Now let's come to an important concept, that is febrile status epilepticus. Now we often use the word called febrile status epilepticus when the febrile seizure is typically lasting for 30 minutes or more. It is often considered as the extreme end of the complex febrile seizure component, and we often consider febrile status epilepticus not be that benign the way a simple febrile seizure is. There is a study on FebStat, which is febrile seizure status epilepticus, and it has been seen that children with febrile status epilepticus when compared to febrile seizures are usually focal. They're usually the first seizure. Even at a lower temperature itself the seizure can happen. It is more common in younger children, and usually there is a longer duration of the febrile illness before the seizure usually happens. So this is the general dictum. That means if a child who is less than 18 months comes to you with a prolonged history of fever followed by a focal seizure, and that focal seizure is prolonged for more than 30 minutes, then think of febrile status epilepticus. Because children with febrile status epilepticus, it has been seen that they are often associated with HIMAL, that's hippocampal malrotation. We have there is also a lot of association between the HHV6 and HHV7 along with febrile status epilepticus. So the only concern that we tend to have is regarding the malrotation, which is very, very commonly associated with febrile status epilepticus per se. So what happens to children with this febrile status epilepticus? They usually have a higher chances of future febrile status epilepticus when compared to simple febrile seizure. So that means the second important thing that we are concerned with febrile status epilepticus is that if the status is persisting beyond 30 minutes, I have a fear that will there be an hypoxic injury following this prolonged status epilepticus. So FEBSTAT studies have shown that if an MRI has been performed within 72 hours of a febrile status epilepticus, it has been shown that 11% of the children will have acute hippocampal injury. Similarly, if the EEG is performed within 72 hours, 50% of them abnormalities can be detected. Right. So why are we interested in MRI and EEG getting performed within 72 hours is that we want to predict that will they have a higher chances of, developing another FSC? Are they at a higher chances of developing a are they at a higher chances of developing an epilepsy? So it has been shown that follow-up MRI might also show hippocampal abnormalities like mesial temporal sclerosis. And it is also known that cognition, short-term memory might also get affected following febrile status epilepticus. So what we don't know is that if at all there is an abnormality on an EEG and MRI which is performed within 72 hours, we don't know how long it will take for the child to develop mesial temporal sclerosis. If the child is having a febrile status epilepticus at 1 year and MTS develops at 8 years, do you I need to give anti-epileptic for so long? That becomes a unanswered question which is there. So this is one of the important spectrum that you should be aware at this point of the time. So that means till now we have covered basically three important conditions: simple febrile seizure, complex febrile seizure, febrile status epilepticus. So simple febrile seizure, generalized, less than 15 minutes, and one seizure per one febrile illness. Complex febrile seizure more than 15 minutes, focal component, more than one episode in a single febrile illness. Febrile status epilepticus when the febrile seizure is lasting for more than 30 minutes. Now, the important thing is how do I evaluate, how do I manage these children with simple febrile seizures and complex febrile seizure? The first thing that I need to know is that my questions that keep coming to my mind is, should I do an LP? Should I get blood investigation done? Should I screen for iron deficiency anemia? What are the chances of recurrence? What are the chances that the child will develop future epilepsy? Now, should I perform MRI? Should I perform EEG or not? And should I prescribe intermittent therapy or should I start the child on long-term therapy? These are some of the common questions that keep coming to your mind whenever you deal with a febrile seizure. The answer is very, very simple. The indication for lumbar puncture is that remember that febrile seizure with signs of CNS infection, such as meningeal sign, altered sensorium, lasting for more than 30 minutes, or bulging AF, then you know that they are at a higher chances of CNS infection. In infants who are less than 12 months of age, the signs of meningeal irritation obviously will be absent. So the AAP says that please consider lumbar puncture. So that means in infants with febrile seizure, you might have to consider for lumbar puncture, especially in children between 6 months to 12 months who are either not immunized with the Hib and pneumococcal or when the vaccination status is not known. The second important thing is that if the child has been already pre-treated with any antibiotic before the child came to your particular center. So these are two important indications in which you might have to consider that could the child be having meningitis. But please remember that the chances of meningitis are very, very low. Okay, so the LP needs to be done either if there are very clear cut meningeal sign, number one, Number two, in infants, because meningeal signs are not going to be seen. Number three is 6 months to 12 months when vaccination status is not known. Number four is that any child who has been pre-treated with an antibiotic. Out of this, the first two are mandatory indication. The second two are optional indication. So these are four indications for performing lumbar puncture in febrile seizure. Now, the next question that comes to the mind is that in febrile seizure, should I send a blood culture? Please remember, bacteremia per se was detected in 1 to 4% of children, with none of them had meningitis. So there is absolutely no role of blood culture in febrile seizure. Similarly, blood sugar electrolyte level. Again, they are not very useful if the child has presented to you with a simple febrile seizure. Similarly, that means there is no role of getting serum electrolyte, blood glucose testing among children with simple febrile seizure. And similarly, there is no role per se of other tests like zinc, vitamin D, and all. So this is one of the diagrammatic way in which I tend to remember in my mind when to do. So five things that I see. Number one is family history. Whether there is a family history of febrile seizure, is there a family history of epilepsy? How was the seizure? What is the development of the child? Was the seizure focal or whether it was generalized? How long did it last? Did it last for only 15 minutes? Did it last a little longer? What was the fever temperature at which the seizure happened? What is the fever seizure interval? And what are the number of episodes? So, five things that I have to know before I take a decision for everything. I need to know at least these 5 or 6 points. So, I'm saying number one is development of the child, family history of the child. These are two things about the child. Five things about, four things at least about the seizure. What was the temperature at which it happened? Lower the temperature at which the seizure happens, higher the chances that it will get recurred. Similarly, fever seizure interval, whether the seizure was focal, whether it was generalized, what was the duration, what are the number of episodes. So five things about the seizure, two things about the child, one development, another is family history. So we need to understand that if the age of the child is less than 18 months, if the temperature was less than 104, if the fever duration is less than 1 hour before seizure onset, that means shorter the duration of fever seizure. If there is a first degree relative with febrile seizure, these are four risk factors. Depending upon how many risk factors happen, the chances of recurrence will increase. That means if a young child is having a febrile seizure, the febrile seizure is happening at a lower temperature. If the fever seizure interval is very less, there is a first degree relative with febrile seizure, higher are the chances of recurrence. I am not talking about future epilepsy. I am talking about chances of recurrence. That means another episode of febrile seizure. So what are the factors? Febrile seizure, the type of the seizure, that's complexity, temperature, fever seizure interval. These are four things that I have to keep in mind whenever I am looking at the factors for recurrence. What are the factors that are chances of epilepsy after febrile seizure? Epilepsy is nothing but unprovoked seizures, right? Even the tendency for the child to have, unprovoked seizures. So we are always worried that will a child develop epilepsy or not? So here we need to understand that complex febrile seizure, shorter duration, family history, right, neurodevelopmental abnormality. So all these things will increase the chances of epilepsy. That means if there is a family history of epilepsy, if it is a complex febrile seizure, I know if it is focal, if it is prolonged, if there are large number of seizures in a febrile episode, if the developmental abnormality is there, and if there is a shorter interval between the fever and the seizure, then these are the children who are at a higher risk for epilepsy. Please remember, here I am interested in two important things about the child. One, development. Second is family history of epilepsy. Two things about the seizure: focality, prolonged seizure, and shorter fever duration interval. So three things about the seizure, two things about the child. These are the risk factors for future epilepsy. Now, what are the indications? When will I do neuroimaging? When will I get an MRI? Simple thing that you need to remember very clearly, there is no indication of neuroimaging in simple febrile seizure. In complex febrile seizure, there is a lot of diversity of opinion. Somebody will say somebody will say something that you should get it done. But in general practice, what we generally tend to do is that MRI is recommended among those with focal neurological deficit. That means the child had a febrile seizure, but there is a hemiparesis. I will never ignore it. If there is a microcephaly, macrocephaly, if there is a developmental delay, if there are recurrent complex febrile seizure, or if there is a febrile status epilepticus. Why am I interested in FSC? Because I know that there are higher chances of hippocampal malrotation, hippocampal malformations, future chances of, developing mesial temporal sclerosis. So these are the children where we require. So that means if it is a febrile status epilepticus, if there are recurrent complex febrile seizure, if there is a developmental delay, micro macrocephaly, if there is a focal neurological deficit, these are indications in which we need neuroimaging. Right? So FSC, it's important so that you are able to predict the chances of hippocampal injury. So when to order an MRI? If there is a developmental delay, focality prolonged. That means multiple episodes of complex febrile seizure. These are the children, especially FSC. These are the children who ultimately require neuroimaging. What is the role of EEG? Remember that predictive value of EEG in febrile seizure for subsequent epilepsy is very, very controversial. That means, what does it mean? That today the child developed febrile seizure, I got an EEG, EEG is abnormal. What is the chances that the child will develop epilepsy later on? There's nothing. So the predictive value is not very, very good. So at this point of time, we need to understand that there are no evidence to support or refute the use of EEG and its appropriate timing in children with complex febrile seizure. In simple febrile seizure, it's a clear no. Okay, so no MRI, no EEG in simple febrile seizure. My doubt comes only when there is a complex febrile seizure. So generally we see that EEG is done among those with more than one complex feature, or there is a family history of epilepsy, or there are any abnormal developmental problem. That means if there is a developmental delay, family history of epilepsy, more than one complex feature. We discussed three, no? So more than one complex feature, then I know that these are candidates who will probably require EEG in such cases. And we need to remember that EEG, which is performed, within 1 to 7 days of complex, might just reveal some non-specific kind of slowing. So many of the times we tend to order EEG beyond 7 days only. So EEG is indicated if there is a family history of epilepsy, if there are more than one complex febrile seizures, complexities, and if there is a developmental delay. So every time we are worried if there is a family history of epilepsy, if there is a developmental delay, if it is a prolonged febrile seizure, if it is a focal febrile seizure, these are all always burning things in which we often get imaging EEG done, right? The next question that comes is, should I give intermittent therapy or not? Remember that intermittent therapy at the onset of febrile seizure is definitely known to reduce the risk of febrile seizure. What drugs do we use? We usually use clobazam, right? zero point 0.5 to 1 milligram per kilogram in two divided doses for 3 days. Intermittent therapy basically means that the child develops a fever. I start clobazam on day one. I continue for the next 3 days, right? But remember that every time the child develops fever, you keep giving clobazam, you'll end up giving clobazam so many times. So there are adverse effect of anti-seizure medication, which is a risk that you need to consider. Okay. So many of the time when we look at the risk, that outweighs the benefit. So at times we often say that there is no clear-cut role of intermittent prophylaxis. Long-term prophylaxis, a strict no in simple febrile seizure. If at all you want to give in febrile seizure, the long term have no role in simple febrile seizure because considering the benign nature of febrile seizure and potential adverse effect of anti-seizure medication. Please remember that whenever you have a problem, always weigh the risk and the benefit. So prophylactic anti-epileptic drugs, yeah, anti-seizures are not recommended for treatment of simple febrile seizure and for most of the cases of complex febrile seizure. Only because parents are apprehensive, don't start valproate. Okay. Many of the times I have seen practitioners also using phenytoin. Please avoid use of phenytoin, carbamazepine, sodium channel blockers in febrile seizures. So continuous prophylaxis with valproate, phenobarbital are known to reduce the febrile seizure recurrence. There is no evidence to as such support use of antipyretic therapy. That means if there is a fever, please don't scare the parents that you have to give paracetamol. So the mother starts really getting very tense. Oh, I have to give PCM. Okay. Round the clock paracetamol at the onset of febrile illness does not reduce. Okay, so despite giving paracetamol, it's possible that the child develops. So don't give parents such false assurance also. Okay, round the clock antipyretic places often a burden on the caregiver every time they will develop fever phobia. Okay, so please be very, very careful that don't give such kind of advice. But yes, if there is a fever, obviously you can give paracetamol in this to relieve the discomfort of the child. Okay, but there is no role of routine iron, vitamin D supplementation unless and until clinically you feel that there are signs of iron deficiency anemia or rickets. Okay, let's just look at few cases and then probably we will be able to understand. This is a 4-year-old typically developing boy with a fifth episode of febrile seizure. It started at 1 year, 2 year, 2.5 year, 3 year, and now the fifth episode. Every time the child has a febrile seizure usually occurs when the temperature reaches 104. It usually occurs within 2 to 3 hours of fever. It's generalized, less than 15 minutes, no Todd's palsy, no meningeal sign. One episode had a fever after the seizure, the fourth one. Okay. Sister had one episode of febrile seizure at 2 years of age, no other family member affected. So again, I use the same diagram to remember. Sister with febrile seizure, otherwise less than 15 minutes, generalized seizure, fifth episode, okay interval, higher temperature, otherwise developmentally normal. So in such a case, this is a simple case of recurrent simple febrile seizure. So we do not require imaging, we do not require EEG, we do not often require any of these medications, intermittent clobazam, nothing, no MRI, no EEG. So recurrent febrile seizure, no other risk factor, no need. This is a 4-year-old child with autism spectrum disorder who developed first episode of febrile seizure. Fever probably occurred after the seizure. See, I'm again trying to emphasize that many of the children with febrile seizure will develop fever after the seizure. So don't say that fever has to always precede the seizure. It's a very common misnotion. Okay. It is quite possible that fever occurred after the seizure. In this child, it was a generalized seizure lasting for 20 minutes, a little higher side. No Todd's palsy, no affected family members. So here I know no family history, but the big burning question is developmental issue, that is autism spectrum disorder. So in such a case, whenever there is a developmental issues in a child with febrile seizure, we usually do not avoid getting an MRI. So we often get an MRI, we often get an EEG done, but obviously LP is not indicated. For prophylaxis, discuss with the parent, discuss the risk versus benefit, whether to give or whether not to give. This is an 18-month-old typically developing boy with third episode of fever seizure in the last 3 months. The fever usually high grade, seizure occurs within 4 to 5 hours of fever. No clear of It's not clear of the type of the seizure, whether it was focal generalized, approximately short 2 to 3 minutes, no family member affected. So 18 month Typically developing boy, third episode of fever, seizure in last 3 months. That means 3 months, multiple episode. Mostly they look like simple febrile seizures in such a case. It just looks like a recurrent simple febrile seizure. In such a case, no investigation, no MRI, no EEG, no prophylaxis, even if there are 5 episodes in 3 months. But do discuss with the parents about intermittent prophylaxis. If the parents are highly apprehensive, you might have to consider for intermittent prophylaxis, but continuous prophylaxis you can still avoid. This is a 9-month-old typically developing boy with 4 episodes of fever seizure in the last 6 hours. Okay. Fever was high grade. The seizure started within 2 to 3 hours of the fever, generalized 2 to 3 minutes. Same story. Okay, 4 episodes of fever seizure. But here, the important thing that you are able to see is that there is no family history, less than 40 minutes, first episodes, more than 1 hour, normal development, generalized seizures. It is basically just the only thing that is happening is multiple episodes. So they are often labeled as SFS plus. So despite being a complex febrile seizure, SFS plus, that means multiple episodes of simple febrile seizure in one febrile episode. Although we call it as complex febrile seizure, we often label them as SFS plus because it behaves like simple febrile seizure. Okay, so here again the strategy will be the same thing. No MRI, no EEG, no intermittent prophylaxis, nothing. No LP, nothing. Okay, this is another child who is a 3-year-old boy with recurrent simple febrile seizure. No family history. 6 episodes have happened till now. EEG from outside done thrice. One record normal, two record abnormal. Okay. MRI incidental arachnoid cyst. The child has already started on sodium valproate from somebody. Now they come to you, doctor, please tell me, should I continue valproate? So what we usually do is smile at them. Now that you have started valproate and the child is doing fine, now the decision becomes really very difficult whether to withdraw that valproate or not. Okay, you take a brave decision to withdraw, the child again develops a febrile seizure, again it comes back on your head whether to, do it or not. So at times in such difficult cases, it's always better to involve parents in the final decision making. This is another child who is 8-year-old boy with fever seizure. Okay, fever seizure interval is 6 hours. It's this started at 1 year. Okay, the febrile seizure started at 1 year, 2 year until now, 5 episodes have happened. Is there anyone affected in the family? The answer is usually no. So please ask the parents how many sisters, how many brothers, and then start asking them. So don't ask such blanket statement that is there somebody affected in the family? They will say nah, kuch nahi. Okay. So here the most important thing is age of the child. Okay, this is an 8-year-old child. We know that it is not a very common thing to have febrile seizure persisting beyond 5 years of age. So, in such a case, often it's not a very good decision to leave it. It is basically a febrile seizure plus. So, in such cases, we often require imaging, we often require EEG, and these are children who will probably also require long term anti seizure medication. Okay, so febrile seizure plus, especially if it is genetic, that means if there is a family history, we usually do not ignore such cases. Okay, this is another 2.5-year-old boy who started with febrile seizure at 1.5 months, had recurrent simple febrile seizure till 1 year. After that, he had few afebrile seizures also. Now, till now, 14, 15, 16 episodes have happened. Mild cognitive impairment, no family history, child already on valproate and phenytoin. MRI normal, EEG multifocal AED. Will you investigate? MRI yes, EEG yes, it's already done. Okay. Now, since you know that the child is having febrile seizures as well as afebrile seizures, so we are always worried that The child is probably now evolving. Another important thing is cognitive impairment. Multiple types of seizure that started like febrile seizure. So this looks like a Dravet phenotype. So in such a case, we need to be really very careful, and we have to discuss with the parents whether they want to get a genetic investigation done or not. Often these children will require anti-epileptic drugs, but please remember that phenytoin is not a good drug. All right, so phenytoin needs to be stopped, and you might have to continue with the valproate in such phenotype. So this is Dravet, which you should never forget. This is another last case. 2-year-old boy brought with third episode of febrile seizure, encephalopathy also, fever for 2 days prior to seizure. That was right focal, continued for more than 1 hour, brought convulsing to casualty. We got an investigation done for this child. He's in altered sensorium, and you can see that the MRI has very typical white hypoxic injury, which you can see. Okay, so this is what we don't want. This is the biggest complication of febrile status epilepticus. So please remember that this is one complication which we want to avoid. So at times we often take a lower edge to start anti-epileptic drug, especially if you feel that there are higher chances of developing another febrile status epilepticus, because we don't want to lose the child and result in complete hypoxic injury, right? So in such cases, we often keep a lower edge if there is a febrile status epilepticus, right? So that means we realized what is simple febrile seizure. That means seizure which is for less than 15 minutes, generalized seizure, one seizure per episode of fever, it's SFS. If it is more than 15 minutes, if it is focal seizure, more than one episode, this is complex febrile seizure. SFS plus is when you have a simple febrile seizure, that means it is less than 15 minutes, it's generalized, but more than one episode in one febrile illness. FS plus is when the febrile seizure is lasting beyond 5 years of age. Febrile status epilepticus is when the child is having febrile seizure lasting for more than 30 minutes. The second thing that we learned is, should we do LP or should we not do LP? If there are clear-cut meningeal signs, do LP. Infants, take a lower edge. 6 months to 12 months, immunization status doubtful. Fourth indication, antibiotic. No role of any routine blood testing done. No role of any iron deficiency and vitamin D levels unless clinically you are finding any signs. Chances of recurrence, I told you very, very clearly that if there is lower temperature, shorter fever seizure interval, family history of febrile seizure, then there are very, very high chances of recurrence. If there is a family history of epilepsy, if there are one or more episodes of complexity, shorter fever seizure interval, higher the chances of epilepsy. MRI, we usually restrict if there is a developmental delay, febrile status epilepticus, family history of epilepsy. Almost similar indication for EEG. Intermittent therapy should be always discussed with the parents. Do not start the intermittent therapy without discussing the risk and the benefits. Long-term anti-epileptic drug has no role in simple febrile seizure. Very few selected cases of complex febrile seizure, especially those with febrile status epilepticus living in a far off place, and you know that they can't reach the medical center. We are always scared that the child should not develop hypoxic injury. In such cases, we often take a decision, especially if there is a developmental delay. If it is febrile seizure plus, if it is a Dravet kind of a phenotype, we often consider long-term anti-epileptic, but do not give phenytoin or carbamazepine. So I thank you for listening till the end and hope you enjoyed um, listening to this lecture. Thank you very much.